well, I think it's critical that the family is involved in palliative care decisions. When end of life, especially in the end of life component of that, is to have the family fully engaged with the patient in making those decisions and understanding what the patient's real priorities are. It's something patients don't necessarily discuss with their family. They don't clearly articulate that, and I think it's important that everybody gets involved, because when dad's sitting in the ICU and decisions have to be made, I think it should be really clear to everybody involved what their wishes were, and that the family has come to terms with those.
It's important we understand that there's so little actual training in how to have these conversations. So I do agree with you that one of the biggest issues for physicians is they are spending their entire developmental career in trying to fix things. And they're not trained at all really in that communication aspect. And so I get that. And we have done in my old practice some time and motion studies, and the average doctor would spend 10 minutes with that end-of-life conversation about the fact that we've tried everything and it's not working and you need to consider hospice. And our licensed clinical social workers who are certified in palliative care counseling would spend 90 minutes having that conversation. And they would have that conversation with the family present, where the doctor would feel compelled, because they just put the CT scan up on the viewer and it's worse, to have that conversation in the office right then and there. So I think that there's a process part. There's a lot of structural elements here to make it work. I don't think it's that physicians can't do it. I don't know if they will choose to do it if they know what's required, and then it would be having the right people involved. But then it's also a matter of doing it in the right place, at the right time, with the right other family members and supportive people there, so it's not just telling a patient who's in shock and devastated at a moment, boom, 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 here it is.
And it may be that they're separate conversations.
Right.
That you have the initial conversation with the patient and say, let's bring in your family, let's arrange for that to happen.
Right.
As you may, and then gives the patient some time to formulate their ideas about it and then discuss it with family. There may be just two separate conversations happening.
Yep.